in less than 30 minutes. And maybe today I'm going to be a little bit faster and skip a few slides because the other speaker is coming at 9. So I'm going to move faster. Okay, here is the schedule: development, anatomy, physiology, diagnosis, pathology, and general pathology interfering with male infertility, and I will focus on the 3 last points. Let's say a word of development of male reproductive tract. Sex of the embryo is determined genetically at the time of fertilization, of course, but the gonads do not acquire male or female morphological characteristics until the 7th week of development. That means that at the very beginning, the male and female reproductive systems develop indifferently. The male gonad is driven by the Y chromosome, and the main gene responsible for this differentiation is the gene SRY. Here are a few figures that you can have a look at later on, showing the differentiation from the 10 weeks fetus on the left to the newborn on the right. The development of the external genitalia in the male is under the main influence of androgens, and these androgens are secreted by the fetal testis. Testis descent is also driven by the androgens, and just to focus on this point, 97% of the male newborns had the testis present in the scrotum before birth, and in less than 1% of the cases of infants, one or both testes fail to descend, and this is called cryptorchidism. And you might have heard about that, and that's why midwives or physicians, when a child is born, they often have a look at the testes in the very beginning of life. Let's skip this slide. Just you will have a look at this later on, just to show you the basis of male anatomy. And you will see the testis, the epididymis surrounding the testis, the ductus deferens or vas deferens, the prostate gland, the seminal glands, and the penis. Here is another one showing the anatomy of the penis and the anatomy of the testis. So sorry for that, we don't have time today, but I'm going to move faster. Let's go to physiology. A little word about endocrinology, and as you all know, spermatogenesis, male reproduction, is regulated by endocrine hormones, and the main regulation is driven by the hypothalamic pituitary axis. First of all, the first stage consists in the hypothalamus, and which is secreting in a pulsative fashion GnRH, just like in the woman. This pulsative secretion of GnRH is stimulating the pituitary, which in response will secrete FSH and LH. And I guess that you've all heard about FSH and LH, but maybe especially in women. In men, FSH is acting on Sertoli cells. And if you want to remember easily which hormone acts on which cells, remember that FSH is acting on Sertoli cells with an S, and LH is acting on Leydig cells with an L. And in response, Sertoli cells will secrete, Leydig cells will secrete testosterone, and all these hormones, FSH, LH, and testosterone, will in return act as a negative feedback on the pituitary and on the hypothalamus. Okay? So, 3 steps: GnRH on the hypothalamus, pulsative secretion, FSH, LH in the pituitary, and testosterone in the testes, and particularly Leydig cells. Just as a reminder, from a clinical viewpoint, the synergistic action of LH and testosterone and FSH is necessary, is mandatory, I would say, for the initiation, the maintenance, and also for the reinitiation of normal spermatogenesis in case it is disrupted. Testosterone is of course very important, and we've talked about androgens, and testosterone acts both as an endocrine we've talked about this negative feedback, this regulation, as an endocrine and a local factor within the testis. So you have two stages of action for testosterone, one general endocrine way and one local and paracrine way to stimulate spermatogenesis. And this is of fundamental importance. A few words about the function of the organs, and I guess that you've had some knowledge about that. The testis, of course, is responsible in the place where spermatogenesis is taking place. Above the testis, you have the epididymis, and this epididymis is also of primary importance because that's where sperm are acquiring maturation and where they are stored. It means that within epididymis, sperm are being transformed, they undergo an evolutive pathway, and we will talk about that later on. Prostate and seminal vesicles are responsible for producing the fluid-forming semen. Testes don't produce fluid or hardly no fluid. The volume of the sperm, of the ejaculate, is originating from prostate and mainly seminal vesicles. Let's move to spermatogenesis. It's a bit complicated, but I'll try to summarize it, and you will tell me if it's relevant or not. Spermatogenesis is a dynamic, complex, and permanent process associating cellular events and molecular or genetic events. And these are, of course, in close relationship. Spermatogenesis during life, spermatogonia are present, it means sperm germ cells. They are present during fetal life, during very early fetal life. Spermatogenesis begins at puberty, and usually it's supposed to be an uninterrupted process until death. And of course, this is one of the main differences between male and female reproduction at this point. Concerning cellular events, maybe you should just keep in mind that during spermatogenesis, cells undergo 3 successive phases. First of them is based on mitosis. Mitosis is conventional cellular multiplication. And the second of them is meiosis. And meiosis is a very particular genetic and cellular pathway which allows the sperm to move from a diploid genetic content to an haploid one. It means that before meiosis, cells are 46 chromosomes, and afterwards there are 23 chromosomes. And all these phases, the 3 together, last a fixed total length, which is approximately 74 days. So maybe you've heard before that total spermatogenesis lasts for approximately 3 months. Okay? The reality is 74 days. The theoretical yield of spermatogenesis is 16 spermatozoa per germ cell. This is theory, because in reality, in physiology, many cells undergo regulation by apoptosis. Okay? So this is theory. Keep in mind that one germ cell gives 16 spermatozoa, 16 mature spermatozoa, but in reality it's far less than that because of apoptosis. And one last point concerning spermatogenesis is that in testis you have permanently some successive phases of spermatogenesis. It means that you don't have one wave of spermatogenesis beginning and the next one beginning 74 days later on. Okay? You have some waves of spermatogenesis beginning all together, okay, within the testis. So when you have a look at histological slides of testis, you can find some different cellular stages, because in some areas you will be at the end of maturation, okay, spermatids or spermatozoa, and in other areas you will find some germ cell or very early cells. Okay, I'll skip this one. You will have a look. You will find the different cellular stages undergoing mitosis and meiosis. Just a few words on a specific cellular population, which is called Sertoli cells. We've already talked about that because they are regulated by FSH. These cells are somatic cells. They are not germinal cells. They are not part of spermatogenesis itself. However, they are very, very important. They are necessary for spermatogenesis because they maintain and they regulate the architecture of the epithelium. Okay? So these cells are absolutely fundamental. I don't know if it's the proper word in English, but in French we used to say they are chaperon cells. Okay? It means that they regulate and they take care of all the sperm cell hanging around. I'll go very fast on that, but we've talked about cellular events, and these are they are in close relationship with genetic events. We've talked about mitosis and meiosis, and as I said earlier, meiosis results in haploid cells. It means that they have 23 chromosomes instead of 46 chromosomes in all the other cells of the body. And this particular genetic event, meiosis, is of fundamental importance too because it's where the main genetic recombination takes place. Okay, so you have first the random chromosomal segregation. You have 46 at the beginning, and they are separated in two parts, 23 on each side. So this is the first random separation. And secondly, you have also what's called crossing over, and you have a figure down on the right. Crossing over means that there are some exchanges of genetic material between the chromosomes, okay? And this is responsible for the huge variability of human genome, and this is very, very important. Here is the star, the spermatozoa. So as I said, it's an haploid cells, and it consists in two main parts: the head on the head first, and the tail. So the head is mainly consists in the nucleus and the acrosome, and the acrosome represents 40 to 70% of the volume, and the tail, which is made of the midpiece, where you can find the mitochondria responsible for the movement of the sperm, and the principal piece. Nuclear and membrane do not stay the same all along spermatogenesis and all along sperm life. They undergo a very important evolution, a very important maturation, and especially during storage and movement in epididymis. This is responsible for the various motility patterns that you can find among spermatozoa, and this is also true when you prepare sperm for ART techniques, or this is also true when sperm undergo physiological capacitation during their way in the uterus and the tubes, because once again the membrane is evoluting. Some proteins are leaving, some proteins are coming, okay? Some fat acids are coming, some other are leaving, and this is responsible for the motility patterns, which is very different from one sperm to another and from one anatomical place to another. And this allows fertilization. I mean, if you don't allow the sperm to undergo this membrane evolution, it won't be able to fertilize. So, just in summary, each of these steps represents a key element in the spermatogenetic process, and defects which occur in any of them can result in the failure of the entire process and lead to the production of defective spermatozoa, reduction or absence of sperm production. Okay, now we're quite done with fundamental science. Let's move to diagnosis. And first of all, of course, and this is the main job of andrologists, the physical examination. So maybe none of you or few of you have seen or have done physical examination, but of course this begins as usual by discussing, by asking the man how he feels, what is his history, or did have some disease or whatever. So this is called anamnesis, and we would ask him about his familial, medical, and surgical history, about lifestyle and sexual factors, about toxic exposure, of course, and about professional background. Then we will move to physical examination, and well, theoretically, a man should be examined first standing and then lying, well, whatever. It does begin with general examination of the body, with inguinal examination, penis, scrotum, testis, and testis should be examined when the man is standing, not lying, the epididymis, the vas deferens, and the prostate. So I won't go into details, but all these items should be checked by the physician. Okay. Once the physical examination is made, the first biological exam that you would recommend to this man is the assessment of the sperm sample, and except in France, most of the labs around the world undergo sperm assessment according to WHO guidelines. So this sperm assessment, this sperm manual assessment, should be done after 2 to 7 days of sexual abstinence, and is best if the sperm is collected at the lab. Just a few words about abstinence. Why do we recommend, why does the WHO recommend these 2 to 7 days of sexual abstinence? This, just keep in mind, just remember what we said about epididymis. Epididymis is the place where the sperm is maturating, okay? But it's also the place where the sperm is stored. So within epididymis, you would have different population of sperm, some quite young, just produced, and not hardly matured, and some of the ones very mature, produced for a few days, and slightly undergoing apoptosis. Okay? So if you don't check, if you don't fix this abstinence period, you would analyze a very heterogeneous population of spermatozoa, and this would not allow you to have a very relevant result for this man. Okay? So checking for abstinence would theoretically allow to lower the heterogeneity of sperm population and would give you a more accurate result for this analysis. Okay? So here are the parameters evaluated in sperm analysis: the volume, the pH, the sperm number, sperm number in concentration, means per milliliter, and of course per ejaculate, sperm motility, sperm vitality, and sperm morphology. I will not go into details because you would have the reference intervals on the results, generally speaking, but just please keep in mind, and it's a andrologist who is telling you that, this analysis is mainly manual, okay? It's performed, maybe some of you are lab technicians, I don't know. This analysis is manual, okay? And as you can see, we evaluate sperm motility, okay? So when you do manual assessment and when you evaluate some living cells which are moving, it can be quite hard to be very precise. Even if you are the best technician ever, even if you are in a very, very high quality laboratory, you should always keep in mind that this analysis should be read with care, because it's not, I mean, it's not like doing an FSH measurement in blood, okay? This is not automated in most of the cases, and this is only manual assessment made by humans on living cells. And this is quite an exception in biology in general, generally speaking. So when all parameters are within the reference interval, we can say that sperm analysis is normal. But, and this is in my opinion, very, very important, normal sperm analysis does not mean that this man is fertile. I guess you would agree with that. So this is better for him and for this couple, this is better for you, but in any cases, normal sperm analysis does not mean fertile, okay? On the other hand, we will see later on that slightly abnormal sperm analysis does not mean systematically infertility. So when the sperm count is low, we would talk about oligozoospermia or oligospermia. When motility is low, we would talk about astenospermia. When the morphology is poor, we would talk about teratospermia. And some of these parameters could be associated altogether, so you could have, for this sperm analysis, oligo-asteno-teratozoospermia. Okay? And it quite often, unfortunately for these men, they are associated altogether. These men could be referred to ICSI, but that's not the purpose of this talk. When there are no spermatozoa in the whole ejaculate, we will talk about azoospermia. And it's not written down there, but in any case, when sperm analysis is abnormal, it should be checked a second time on another sample. Okay? This is very important. Secondly, a slightly abnormal sperm analysis does not mean infertility. So that's what I said just a few seconds ago. And finally, every man experiences a high intra-individual variation. This is physiologic, okay? So if you had some men undergoing sperm analysis every 10 days or every month for a long period, I mean, why not for a research purpose or whatever, you would see that most of the time you would never have two consecutive times the same results. Sometimes the motility is better than the previous one, sometimes the sperm count is lower, and so on. Okay? So that's why, once again, sperm analysis is of fundamental importance, has a pivotal role in andrology. However, in some way, it's quite a poor assessment, and it should be checked at least one time. What about endocrine analysis? Well, there is no surprise, as testosterone, LH, and FSH are regulating spermatogenesis. Well, endocrine analysis deals with testosterone, LH, and FSH. And most important are LH and FSH. I mean, testosterone is not a very sensitive parameter. Most important are LH and FSH. And they allow to identify the origin of spermatogenesis failure. I mean, they allow to distinguish between central and peripheral origin. If a man has a very low FSH and LH and a low testosterone, this would probably be linked to central origin. However, if on the contrary, if you see that FSH and LH are very high, it means that that spermatogenesis is disrupted, but not at the pituitary step. Okay, so pituitary is trying to reinitiate spermatogenesis and is secreting high levels of FSH and LH, and this is what is often seen, for example, for non-obstructive azoospermia, which is of peripheral origin, testicular origin. Ultrasound is also very important, okay, when evaluating male fertility, and particularly testis ultrasound. I won't talk about prostate ultrasound today. I don't know very much this parameter, but testis ultrasound may be more important. It allows the andrologist or the physician to evaluate the volume and the structure of the testis, okay, because physical examination would allow to detect some defects, okay, some nodules, maybe some small size or whatever, some defect in testis, but it's not as sensitive as ultrasound, okay? And particularly when you talk about testicular tumors, and you might know that testicular cancer, unfortunately, is of increasing prevalence, especially in Europe, but maybe you've talked about that recently in epidemiology, but testicular tumors, testicular cancer is of growing prevalence, and sometimes these tumors are infraclinic. They cannot be detected through physical examination, okay? So this should not be forgotten, and ultrasound is generally recommended to go further after physical examination. Okay, a few words about pathology of male reproductive system. First of them is obstructive azoospermia, and the most frequent situation is the congenital bilateral absence of vas deferens, known as CBAVD. Okay, so maybe you will remember this slide about anatomy. You have the ductus, the vas deferens between the epididymis and the prostate and seminal glands. And when there is no vas deferens for any reason, of course, there is no spermatozoa in the ejaculate. Okay? So the main etiology, the main case, the most frequent case is cystic fibrosis. And cystic fibrosis is associated with CBAVD in more than 95% of the cases. All CBAVD are not cystic fibrosis. All cystic fibrosis do not have CBAVD, but this is the most, from far, the most frequent association. Okay? So in this case, endocrine analysis is normal. Why is that? Because spermatogenesis is normal. This is an anatomical problem, okay? Some would say a problem of primary, but there is no problem with spermatogenesis, okay? The only point is that spermatozoa fail to reach the ejaculatory duct. So this can be overcome if the couple agrees with that, of course. This can be overcome by surgical sperm retrieval followed by ICSI, but in this case, of course, one should never forget to undergo genetic counseling, because everyone has to keep in mind that cystic fibrosis, of course, is very important. It's a very important disease. And the point is that you should avoid, of course, obviously, to give birth through ARTs, through ICSI, to a child suffering from cystic fibrosis. So you should examine the woman before undergoing surgical retrieval in the man and undergoing ICSI. Concerning non-obstructive azoospermia, there are several etiologies, but unfortunately, and this is one of the big problems of andrology nowadays, most frequently these NOA are unexplained. More or less, it depends on your experience and on the books and on the articles you read, but more or less, more than 2/3 of the cases remain unexplained. Okay? So you have the well-known congenital origin of non-obstructive azoospermia, such as the Klinefelter syndrome. You have the acquired one, like the post-chemotherapy, but most frequently it's unexplained, totally unexplained. And this is quite hard to explain to the men. Just saying that there is azoospermia, we are sorry about that, but it has been confirmed. But what the reason, what the origin of that, nobody knows. There is a frequent association with testicular hypertrophy, okay? And in this case, endocrine analysis is not normal as it was in obstructive azoospermia. I mean, in these cases, as testicular stage is altered, as spermatogenesis is disrupted, the pituitary is trying to regulate this defect, and you have a high FSH and LH level. Testosterone is not very sensitive, and sometimes it's low, sometimes it's normal, but whatever. The most important point is that FSH and LH are very high. Surgical sperm can be attempted in these cases. Once again, if the man is okay with that and if the couple agrees with ICSI. And depending on the cases, once again, you can inform your patient that the success rate of the surgical retrieval is between 30 and 60%. It means that on average, less than one man out of two will have residual remaining spermatogenesis within the testes. And once again, genetic exploration should be performed with a karyotype and so on. So I'll skip this one, these other pathologies, but just keep in mind that testicular cancer is of growing prevalence, is of growing importance, and this is quite a problem for everyone, because we don't really know what's the origin of this growing prevalence of testicular cancer. It's beginning to be maybe the first, if I remember well, the second most frequent cancer in young men. So even if the healing rate is very high, more than 95%, something is going on with this, and it might be associated with the increasing prevalence of cryptorchidism in newborns. And finally, a few words about general pathology interfering with male fertility. So we've talked about the genetic abnormalities, chromosomal or molecular abnormalities, such as cystic fibrosis, for example, or Klinefelter syndrome, central hypogonadism. You have the abnormalities of androgens synthesis or action, diabetes, and diabetes also, its prevalence is increasing in Europe and in America, and diabetes most frequently is not associated with spermatogenesis alteration, but rather with retrograde ejaculation. It means that at the time of ejaculation, the sperm, instead of going out, is going up in the bladder. Okay? So this is very important to look for in men suffering from diabetes, because you can retrieve, you can even do a sperm analysis, or you can even prepare sperm for IVF or IUI or any technique you want. You can retrieve sperm, living sperm, within the bladder. Okay? So this is very important. Cancer, of course. Cancer itself, whatever the kind of the type of cancer, cancer itself can have an impact, deleterious effects on spermatogenesis. It does have systemic effects, such as fever and inflammation and whatever. But cancer, of course, means chemotherapy and or radiotherapy. And chemotherapy is one of the most deleterious agents for spermatogenesis. Okay? So this is part of the anamnesis we've talked about earlier, just to ask men if they have suffered from cancer and if they have undergone chemotherapy, even when they were very young. I mean, a leukemia for a young boy, which is 2 or 3 years old, most frequently means as a spermia when he's a young adult. The use of recreational drugs, okay, this is not very frequent in our population of patients coming to the ART centers, but it can be quite frequent. And I agree with you, Frida, that some of these men, they would not admit that they use cannabis, but this is true. And steroids. Men taking steroids for sport, or whatever you call that, for bodybuilding. Steroids is androgens. Androgens has an impact on spermatogenesis, remember, and these steroids do exert a negative feedback on the pituitary. So this would result, think about that, these men doing bodybuilding, taking steroids, this would result in small testes. They should know that before. Spinal cord injury, I don't do bodybuilding. Spinal cord injury, maybe you would not believe me, but I don't. Heavy alcohol intake, heavy smoking, and I'm very interested in smoking, and this does result in sperm alteration and morbid obesity. Last word before I leave. Treating infertility means treating a couple, not only a woman. Okay? You know that, but it's better when you say that again. And knowing the placebo effect of medical attention and applying it in treatment strategies is just as much a part of evidence-based andrology as its scientific basis. It's not my words. This is taken from a famous book, which is described here, the Nishlag. But I guess that this is also of fundamental importance, that in our field of interest, in reproduction care, generally speaking, we should care too of men.